Great. Hello, everyone, and welcome to the Rural Emergency Hospital Conversion and Technical Assistance webinar. My name is Candace Talkington, and I'm the Manager of Strategic Planning here at Rural Health Redesign Center, and I will be your moderator for today. We have a lot of information to cover. Excuse me. If you've attended one of our previous Rural Emergency Hospital educational webinars, some of this information might look a little bit familiar, but however, we do take time to adjust the content to address the most recent questions, so things might look a little bit different, somewhat similar. We're going to start with an overview of the Rural Emergency Hospital policies and requirements of conversion. We'll also share details about the no-cost technical assistance available to rural hospitals who are considering conversion, including the financial analysis reporting. We have also preserved some time at the end to address your questions. We've looked at both questions that came in prior to the webinar, as well as taking questions from you live today. Finally, we'll close out by sharing where you can find additional resources and information about rural emergency hospitals. The Health Resources Services Administration of the U.S. Department of Health and Human Services funds the work of the Rural Emergency Hospital Technical Assistance Center. I'm so very excited to share with you our speakers for today, Janice Walters and Shule Jarovich. Ms. Walters is a highly rated rural health expert with over 20 years of leadership and healthcare finance experience. She works closely with rural health executives, state and federal programs, and other community partners to ensure rural communities across the U.S. have access to quality healthcare. Janice has overseen the implementation of the Rural Health Redesign Center initiatives, including Pennsylvania Rural Health Model, as well as the Technical Assistance Centers for the Rural Emergency Hospital and Rural Northern Border Region Healthcare Support Programs. Dr. Jarovich is a senior fellow at Mathematica with experience in hospital global budgets, hospital finance, and all payer claims databases. Shule is deeply familiar with the payment reform in rural hospitals. She has supported the Commonwealth of Pennsylvania with the implementation of the rural health model and worked with hospitals in Washington state to assess financial impact of CMS's community health access model. She is also currently working to the reconstruction of hospital payments and budget review process in Vermont. Before I turn it over to our speakers, I'm just going to go over a few housekeeping items with you. All participants are muted to prevent inadvertent background noise. However, we would like this to be an interactive session, so we've put some polls throughout to keep the brain flowing. For the best quality experience, we do encourage you to use the Teams webinar link rather than just the call-in feature to access the presentation whenever possible. We do welcome your questions and ask that you submit them using the Q&A feature at the bottom of your screen. Please use the chat. Please avoid using the chat feature to submit your questions. We may miss your question if you submit it through the chat feature. So again, use the Q&A feature at the bottom of your screen. For those of you who wish to use the closed captioning feature, if you do not already see this transcription on your screen, you may click More at the top of your screen, then select Language and Speech, and then from there you may choose your preferred language. A fully accessible version of the slides and recording will be emailed to all registrants and will be available at the Rural Health Redesign Center website about a week after today. And with that, just a reminder that we are recording today's session. All right, so just to outline some objectives for today's webinar, we're going to provide an overview of the rural emergency hospital provider type. We're also going to share with you key policies and conversion requirements for the rural emergency hospital. We'll also hoping to learn more about the types of technical assistance needed for those hospitals that are considering an REH conversion. We're going to describe for you technical assistance available at no cost to hospitals who are considering that conversion. And then we're going to offer you a chance to ask questions, as I mentioned at the end. All right, so just to get us started, I'm going to launch our first poll. And this poll is really just started asking about your experience with attending previous webinars related to rural emergency hospitals. So you should see a poll pop up on your screen. Go ahead and respond. Yes, you attended previous webinars hosted by the Rural Health Redesign Center. Perhaps you have not yet attended one of our webinars related to the Rural Emergency Hospital. Maybe you don't remember. Maybe you've attended some webinars and you're just not quite sure if it was us. Or maybe you have attended other webinars related to Rural Emergency Hospital not hosted by us. So go ahead and submit that. I'll give you about 60 seconds to finish up. Okay, maybe 10 more seconds, and then I'll share the results with everyone. Okay, and you all should see results on your screen. Looks like most of you have, about a little over half have not previously attended. Maybe about a third of you have previously attended one of our webinars, and then fewer of you have attended other webinars. Thank you. All right, one more poll for you, and then I will turn it over to Janice, who will take us through the next several slides. So this one's asking more about what you're hoping to learn from this presentation. So launching the poll here, perhaps you're hoping to learn a little bit more about what an REH is. Maybe you want to dig into policies and requirements. Some of you might be more interested in the application process. And then perhaps others of you are really just looking for what kinds of technical assistance might be available for you. And maybe you're a hospital, you're not considering REH conversion, but you're looking to see how can you coordinate with other rural emergency hospitals. And if there's something else, feel free to just mark something else. I'll give you about 20 seconds or so to finish up the poll. All right, I'm going to close it out. All right, looks like most of you are interested, about a third of you are interested in policies and requirements. Some of you are looking for more of a description. Looks like some of you are interested in the application process. I'll take this opportunity to let you know that we're going to go through quite a bit today, but there are several slides available in the appendix that we won't go over today, but it will be available if you download the presentation. One of those is a detailed description of the application process. All right, so with that, I'm going to go ahead and turn it over to Janice, who's going to give us an overview of the Rural Emergency Hospital. So Janice.
So certainly thank you, Candace, for launching today's session. And we certainly do hope that the folks that have chose to join us today do find the content that we're providing valuable. Our role as the TA Center is to help hospitals on a journey, and certainly educating folks about the Rural Emergency Hospital designation is one of our primary goals, and hoping to achieve that today. So really, at the highest level, what is the Rural Emergency Hospital designation and why was it created? So certainly, anybody that is familiar with rural healthcare knows that, we have seen a lot of rural hospitals close over the last many years. And so really the Rural Emergency Hospital designation was an attempt. It's a new Medicare provider type that could produce an alternative for rural hospitals to consider to assess if it actually creates a viable path forward for those hospitals, really with the primary goals of averting potential closures of rural hospitals, allowing continuation of essential services, and then advancing health equity through access to care. This designation actually became available January 1st of 2023. One thing of note is the December 27th, 2020 date is a very important date, and we will certainly reference that several times through the presentation today, but this act was actually passed and established on December 27th, 2020, making this new licensure type available as of January 1st, 2023. As it relates to eligibility criteria, the list on this slide really reflects the eligibility requirement, and we will discuss some of these talking points in more detail later on in the presentation. But to qualify for an REH status, the hospital must first be licensed as a critical access hospital or a rural prospective payment system hospital with fewer than 50 beds as of December 27th, 2020. Again, that date is really, really important as it relates for assessing eligibility requirements. They must be enrolled as a Medicare provider. So some organizations may not qualify if they're not individually licensed as a Medicare provider. They also have to meet staffing, training, meet staffing, training, and certification requirements, including emergency room staff. There is criterion that you have to manage and maintain an average length of stay across a 12-month period, an annual average length of stay of less than 24 hours across all REH services, and we can provide a little bit more information on that. And then meeting the conditions of participation, having to be a level 1 or level 2 trauma, have to have a partnership, with a level 1 or level 2 trauma center, etc. And we're going to jump into a little bit more detail on all of these as we move forward with the presentation today. So what REH services must be provided? What must the rural hospital continue to do as an REH? They must maintain 24/7 emergency and observation services, again, within an annual average length of stay of less than 24 hours across all REH services. So it's not simply observation care, that falls into that category, but it's literally all the REH services that are paid based on the outpatient fee schedule is what goes into that average length of stay. They also must provide diagnostic lab and radiological services, along with a pharmacy drug storage area, and then they also have to have discharge planning in place by a qualified professional. The REHs do not provide inpatient care, but must have agreements with hospitals to transfer patients when needed. So again, that transfer agreement with a level 1, level 2 trauma center is a requirement of the REH. But beyond what an REH must provide, there are certainly other things the REH can provide. And so this list is not meant to be exhaustive, but certainly we do want folks to know that while, you might have to give up inpatient care, you can continue to provide a plethora of services in the outpatient arena. And, as we work with hospitals that come to our TA center, we actually work to help you identify, there might actually be opportunity for you to expand outpatient care within the REH and the new reimbursement structure. But again, that's some of the technical assistance that we provide to you. But again, there's a lot of things the REH can do in exchange for giving up the inpatient care and the swing bed care. They're actually encouraged to expand outpatient treatment or outpatient options in their communities. Of course, part of what we do here at the TA Center is really understand, okay, in exchange for maybe an enhanced payment. So obviously the REH is paid differently. There is some different payment mechanisms within the REH framework, one being a fixed facility payment. There is enhanced outpatient payment off of the outpatient fee schedule, an enhanced payment of 5%. But in exchange for those gains, obviously there's things that you have to give up. And so really, as we sit here in the TA Center with our very skilled team of folks on staff here to help folks, really that's what we help sort through is understanding how does that gain versus loss, I would say, balance out from a scale perspective, and actually is the gain more than the loss as it relates to balancing that and determining if the REH designation is the right thing for a community to pursue. There's also conditions of participation. And again, our goal today is not to provide you a comprehensive list of everything that one needs to know in order to become an REH, but really identify the key points. And then again, we in the TA Center are sitting here ready and able to help you work through the specifics of all of this. but certainly there are conditions of participation that the rural emergency hospital must maintain, meet and maintain. A lot of these do look very similar to that of the critical access hospital or the PPS hospital, such as staffing, clinical and non-clinical, nursing services. Again, it looks very similar to the REH with the exception of with the exception of the critical access hospital, the PPS hospital. It looks very similar with the exception of the inpatient requirements currently that critical access hospital and PPS hospitals would have to maintain. Patient right agreements, blood products, physical requirements, radiology services, pharmaceutical services, laboratory services, imaging services, and infection control. There's conditions of participation around all of those various aspects of care delivery that the rural emergency hospital is expected to meet. I'm going to talk a little bit about the REH conversion process and just providing. So that was some of the requirements, some of the things that you must meet, the eligibility criterion that we just briefly covered, conditions of participation, etc. Now we want to talk a little bit about what that conversion process looks like. Again, in the spirit of just high-level education for those that are joining us today. REH enrollment and converting back. One of the questions that we frequently get here at the TA Center is, if I convert to a rural emergency hospital, is there a path back to my current designation? And so again, just trying to identify some of these key points for you. So certainly the enrollment process begins with the state agency, CMS, or the CMS contractor survey. And that process needs to be complete and remains effective until the hospital either elects to revert back to the REH or stay as an REH or convert back. So there's an enrollment process for a critical access hospital. That enrollment process is actually a conversion process. For the PPS, it looks more like a new application. There's some nuances there as it relates to that enrollment process. But once you become an REH, there is a path back generally, but in order to convert back, the REH would have to meet all current conditions of participation as a critical access hospital. And so really, and same thing PPS, if you decided REH wasn't right for you and you wanted to go back to your prior, designation, it's really an application, a new application as of that period in time when you wanted to convert back. Where that creates an issue is for critical access hospitals that have received their designation based on necessary provider designation, because we all know that ability to be deemed a necessary provider at the state level no longer exists. And as a result of that no longer existing, in order for an REH to become a critical access hospital, they would need to meet all current CAH conditions of participation, including mileage requirements and all of that. So that's a question that we get quite common. If I decide to become an REH and it's not the right path for me, can I go back? The answer is yes, as long as you meet all current conditions of participation for that designation, either the PPS or the critical access hospital. And it does create a hurdle for a necessary provider if they cannot meet all of their current critical access hospital conditions of participation. So again, offering that here because we have heard that a lot. And to Candace's point in the opening, trying to hit the questions that we've heard frequently to educate the community today. As it relates to the application process itself, it is a multi-step process, and there's certain requirements that have to be met. Again, our role in the TA Center is to provide you that step-by-step direction as you migrate through this process. So as part of the application process, there is an application plan, an action plan that must include the description of the services and staffing provisions of what the hospital is going to continue to do, what the Rural Emergency Hospital is going to continue to provide, as well as the services that it's going to give up, and also the transition plan of when those changes will occur. In addition to that action plan that needs to accompany the formal application, you have to, as I already mentioned, have a transfer agreement with a level 1 or level 2 trauma center in place. That's the minimum requirement. Another question we frequently get is, well, what if I already have transfer agreements in place with other providers? That's okay. You can keep them. We're not looking to disrupt maybe good transfer patterns that you already have. But as an REH, you are required to have an agreement with a level 1 or level 2 trauma center as a minimum standard. Certainly, you can have more than that. And then attestation to meeting the REH conditions of participation. So as part of the application, there's an attestation where the authorized official for the organization can attest to meeting the current conditions of participation. We often get a question of application timing and what that looks like. You know, how quickly can this happen? And that's a really, really difficult question to answer because the short answer is it depends. It depends on a number of things. It depends on how good the application was actually put together. If there's an incomplete application, that of course is going to extend the approval time. If the state is not ready to go with the REH licensure or regulatory requirements, licensure requirements at the state level, that also can delay. So generally, we see it a several month process. But again, there's a lot of things that, you know, some go through much sooner. I think our quickest time was 3 weeks from one of our facilities from the time they submitted their application till they got notification that they didn't receive their official letter within 3 weeks, but they had received email confirmation that everything had been accepted. I think that's the shortest time, 3 weeks, but then it can go up to months, again, depending on the completeness of the application and the readiness of the state. Rural definition. So this is another area that we've started getting a lot of questions on. And so wanted to bring it up as part of this education session. You know, meeting the rural definition and when that rural definition needs to be met. And again, the December 27th, 2020 date is the key date of defining or determining if you meet the rural emergency hospital eligibility criteria. You needed to meet the bed count, as well as the rural status as of that date. And so we get that question. And again, we wanted to tee that up here today. The other thing that we want to highlight is REHs do not need to meet a distance requirement. So again, if you were eligible as of December 27th, 2020, as an eligible facility, the critical access hospital or the PPS hospital that meets the appropriate rural definition, that's what qualifies you. You don't need to meet distance requirements like a critical access hospital does in order to submit an application. Another question that we get a lot is a bed count. So how do I determine that less than 50 beds? It does not depend on your license. It actually goes back to a calculation. And we're putting the calculation in front of you so that you can see that. And again, no more than 50 beds, both at the time the RH designation was enacted, which is that December 27, 2020 date, and the most recent cost reporting period. So the OPPS, the guidance is not overly clear on this. We've gotten this question. We have gotten this guidance directly from CMS that actually it's 2 periods of time that are looked at to actually qualify, ensuring that you met it as of December 27th, as well as currently are meeting that criteria. Again, this comes back to the Medicare dependent hospital calculation. So it is not dependent on licensed beds, but it really goes back to the cost report and providing that for you on screen, as well as some of the worksheets within the cost report where you can find the information to do this calculation. Similarly, another question that we get is what other distinct units can the rural emergency hospital own and operate? At the end of the day, the only distinct unit as the regulation law sits as of today, as the statute sits as of today, the only distinct unit that a rural emergency hospital can own and operate is a skilled nursing facility. So we do know that that creates a barrier for some critical access hospitals as it relates to swing bed. We certainly know that swing bed patients require a qualifying inpatient stay in order to get to a skilled nursing facility. We certainly identify those barriers as we work with hospitals. But again, you are allowed to own a skilled nursing, but again, you're not allowed to provide the inpatient care to meet that qualifying stay requirement. The REH must certify the distinct part skilled nursing unit with CMS. It has to be a separately licensed and distinct unit. And again, that the skilled nursing admission is still subject to the 3-day stay requirement, which does create a hurdle for some hospitals to make the REH conversion. Reporting requirements. We do get this question not quite as frequently as maybe some of the other ones that we've just talked about, but certainly there are ongoing reporting requirements for the rural emergency hospital. So rural emergency hospitals are still required to file cost reports. And the cost report does mirror the critical access hospital requirements, so there's not a lot of change there. We do like to make the point that while the cost report is still required, the rural emergency hospital is no longer cost-based reimbursed. Against that cost-based reimbursement is replaced by the fixed facility payment, and then the enhanced outpatient fee schedule of fee schedule plus 5%. Quality reporting, we do know that the rural emergency hospitals will be required to do quality reporting. There's more information that has come out specific to those measures. And so again, that reporting requirement is still there. And so certainly working with folks to make sure that they can meet those quality requirements is work of ours, as well as the HQICs that have been assigned to rural emergency hospitals. Speaking about the measures, these are the current measures. I believe as of today, they are still proposed. I'm looking to my team to know to tell me if these have been finalized as part of the final OPPS or not. But certainly these are the requirements as proposed, waiting final approval as part of the OPPS ruling. So abdominal computer tomography, so abdominal CT, median time for emergency department arrival to ED departure, facility 7-day risk standardized hospital visit rate after outpatient colonoscopy, so outpatient procedures, and then the risk standardized hospital visits within 7 days after hospital outpatient surgery. So really, as I look at these, I think of these as assessing, the appropriateness as well as the efficiency of care provided at the rural emergency hospital. And of course, then negating follow-up, hopefully getting good high quality care in the REH that would avoid future hospital stays as a result of that outpatient visit. So at this point, I'm going to pause and I'm going to turn it back to Candace, and she's going to launch another poll, and then we will continue. Candace, you're muted.
Excellent. Thank you so much. I'm seeing that your questions are coming into the Q&A feature within Teams, and definitely keep your questions coming. And again, just encouraging you not to use the chat function, but to use the Q&A function at the top of your screen. Okay, so launching the next poll, we're asking, after hearing what Janice sort of laid out for you, if you happen to be a hospital who is considering conversion, do you think that after hearing this, that you would qualify? So I'm going to go ahead and launch that poll, and maybe the answer is yes, maybe no, maybe you're not quite sure. You might be somebody who you might be representing a hospital who's not really considering REH conversion, which is perfectly fine. Or maybe you represent a different type of organization, not a hospital that would be considering an REH conversion. So please just select one, whichever one applies to you. We'll give you about 20 seconds to finish the poll here. And again, we'll get to your questions here in just a moment. Keep those coming in as well. All right, about 5 more seconds to finish up. So it looks like about a third of you, a little less than a third of you, do believe that you would qualify based on the information shared. A few of you are not representing hospitals. It looks like over half of you are not representing a hospital, which is perfectly fine. We welcome you. All right, one more poll before we get to your questions. I'm sorry, before we describe some more of our services. How would you rate your readiness? So this is for hospitals that are considering REH conversion. Feel free to skip this question or answer appropriately. How would you rate your readiness to consider an REH conversion? Perhaps you're ready right now. Maybe you're going to be ready in about 3 to 6 months, maybe in the next year. Maybe you're still considering whether or not you want to convert as a hospital. And again, we know that there are several of you that are you're a hospital, but you're not considering REH conversion. Maybe you're just looking to partner with an REH, or maybe you just don't know. You're not quite sure. So select one response here, whichever was most appropriate for you. And I'll give you about 20 seconds to finish that poll. Okay, about 5 more seconds. Okay. So here it looks like a little over 10% are ready in the next 3 to 6 months. Some of you are still considering. And again, recognizing that there are several of you who are not representing hospitals or representing hospitals that aren't necessarily considering a conversion. Okay, so with that, I am going to turn it over to Shulay. Oh, sorry, still Janice. Janice, you're going to talk a little bit about technical assistance.
Sure. Thank you, Candace. So yeah, certainly the first part of, what we've talked today about is, eligibility criteria, what the application process looks like. And now we want to educate a little bit about who we are as an organization and what we're prepared to do, and how we're prepared to assist hospitals that are considering this designation. So certainly, wanted to share with all of you our mission as an organization, the Rural Health Redesign Center. Certainly our mission is to protect and promote access to high quality healthcare for residents of the Commonwealth as well as other states, to ensure that high quality healthcare remains in rural communities by encouraging innovation in healthcare delivery. So at the highest level of our organization, we are passionate about ensuring access to high quality healthcare remains in rural communities across the country. And our vision is really to help rural communities thrive through improved health. And so certainly, we take the charge that we've been given as the TA center. We take, I consider it a trust that we've been given to work closely with the rural emergency, the rural hospitals that we work with in considering this designation. And again, at the end of the day, our goal is to make sure the right decision is made for the community. And that may be to convert to a rural emergency hospital, and it may be to stay as you are. So again, our goal is not to convince people that the rural emergency hospital is the right designation for them, but rather facilitate a process that they can make the right decision for the community, which we feel squarely aligns with our mission and vision as an organization. How we approach our work, we have some guiding principles that we live by here at the Rural Emergency Hospital Technical Assistance Center, which is the RHRC. We have some guiding principles that we live by, and really that's of service. We are here to serve, all of the folks that reach out to us to seek help, and we promise to do that with, the highest level of excellence. We respond quickly. We don't believe in making people wait a couple of days for our response. Rapid response is one of the things that we commit to, because we really want to bring value to every organization that we have the privilege of working with. So that's really who we are as an organization. Service is at the heart of what we do. And we bring that lens to our work in supporting hospitals considering the Rural Emergency Hospital designation. Who we are as the REH-TAC Center, if you hear the TAC Center or Technical Assistance Center, we're really a collaboration. So we, the Rural Health Redesign Center, are the lead organization, but certainly we have brought very, I say, top-notch, best-in-class vendors to the table to work with us, because we certainly are not expert in everything. And we really feel like with the collaboration that we've been able, the partners that we've been able to bring to the table, we can offer best-in-class technical assistance. But the beauty of it is it's free of charge to those hospitals that work with us, because HRSA is so graciously funding all of our work. And so who do we have at the table with us? We have Mathematica colleagues doing a lot of our financial assessments. And I would say doing the deep dives into, does the math work, is like I like to frame it. We have other folks expert in EMS, rural EMS, because we know rural EMS is different than urban EMS. We bring some marketing, again, the community engagement, the community involvement. We understand the difficult message that this can be for some communities. And so we support that marketing effort, as well as some legal advice. And so we have more. We're always looking to expand and broaden the TA capacities at the center, but we really do feel like we have brought together top-notch vendors that we partner with within the Technical Assistance Center. How we do our work, we work collaboratively with other people. We work collaboratively with, for example, HRSA, the various offices of state, the state offices of rural health, the flex coordinators. We really do want to partner with folks that are already in this space. They already know these communities. We're not looking to replace, we really are looking to partner and be a collaborative partner with other folks already in the rural health space. Again, we commit to respond quickly. We also protect the identity of any organization, any hospital that reaches out to us and say, hey, I'm interested in assessing this. We actually sign confidentiality agreements where we will not share their names. And we also ask them not to share the names of other folks that they might become aware of, because we understand the privacy that needs to be given to these communities as they make this assessment. I like to say, you, the hospitals, can tell anybody that you want, but we will not tell anyone other than those that we absolutely have to in order for us to do our job. We provide one-on-one rural relevant expertise. And so again, we have a lot of people on our staff that are really experts in rural health. We support strategic planning, again, because of our rural relevant expertise, because of the work that we used to do in rural communities ourselves. We understand what it takes to do strategic planning in rural communities, and we want to offer that to you as well. And then certainly we assist with the application process. Again, there's a wide array of things that we can do. I'm not going to read the slide to you. You can certainly see it. But again, we offer all of these services at no cost to the hospital, because HRSA has agreed to provide the funding for us to do our work. We're also giving you some testimonials of folks that we've worked with, just so that you don't have to take our word for it. We have folks out there that have actually, really found a lot of benefit in terms of the how we do TA, how we create a community experience, so that you can not only learn from us, but you can also learn from other peers in this space that are on a similar journey. The conversion process, we've already talked a little bit about this on the timeline, but what does it actually look like? We help to determine eligibility. So again, am I rural? Do I meet the bed count? We're here to help you assess that. Assess the journey, assess the benefits, the value proposition. What do I gain in exchange for what do I have to give up? We support the application process, the conversion process. And then for those hospitals that do convert, we will stay with you in the post-conversion space as a rural emergency hospital and continue to provide you valuable TA. What that looks like from a timeline perspective, as I said earlier, it can be quick. Anywhere from 1 to 3 months is what we're really seeing. Some of the hospitals that joined us in cohort 1, we're still working with. because they're not, the journey is longer for some of those. And so these are general timelines. We're here really to walk with you on the journey. And again, I think currently we're working with about over 50 hospitals on the journey. Again, what other services do we provide? You folks can read this slide. We're going to make it available online, but certainly we offer a lot of support to hospitals that reach out to want to work with us. As I've stated, we are currently working with about 104. We are working. I should say, we've received outreach from 104 hospitals across the country interested in learning more about the REH designation. So that is a very live statistic as of today. 104 hospitals across the organization have reached out to at least get educated on what the rural emergency hospital means. About 50% of them move on to say, okay, maybe it's worth my time to actually see what the modeling might look like. So currently we are working with 3 cohorts of hospitals. Again, some of our cohort 1 hospitals that we started working with in early 2023, we are still working with. But we are getting ready to, I would say, launch our fourth cohort. That will begin in January 2024. So after this call, if you think I'm a hospital, I'm interested in learning more, please do reach out to us, and we will certainly get you in that process as part of our cohort 4. I'm going to pause right now, and I'm going to turn to my colleague, Shule Garovich, and she's going to talk a little bit about the financial assessments and the financial tools that we provide as part of our technical assistance. So Shule?
Thank you, Janice. And if you can advance to the next one. Before I get to the financial one, I also wanted to iterate the cohorting approach that the REH is taking. It's really valuable to not only get services from us, but create that community and talk to your colleagues to understand a little bit the same journey that you're going through. My team at Mathematica provides the data analytics and the financial assessment. We do have access to various of data sources that we built together. What we call a financial assessment tool, where we look at the cost of conversion. So the first step is to compare your current Medicare and all payer revenues to what happens if you convert to REH, and what is that one-on-one comparison using the same assumptions for that conversion year. And then from there, we also build models to look at your future trends. As Janice mentioned earlier, the simple math is really a look at your inpatient revenue and compare that to the facility revenue. But as the outpatient reimbursement changes with the REH status, there is more complications as you start building the financial implications of the conversion. On the cost side, we do build detailed assumptions and estimates to estimate potential scenarios for potential savings on the inpatient side, but potentially more cost on the outpatient and ED services, as some hospitals may expand services on the outpatient setting. The data sources, as I mentioned, are quite in-depth, starting with the Medicare cost reports. We also ask some additional data from the hospitals who are interested in financial assessment. And we also use the National Medicare Claims Database to estimate the implications on critical access hospital payments. Next slide, please. So that's the big question, by no means the only question as you are thinking about the REH conversion. What is the financial models going to look like? But there are also other decisions that the hospitals would need to evaluate, assess, and there we are supporting the hospitals through ad hoc and some canned reports, as we can say, to look at the potential changes the hospitals might be planning and what the implications are. So we could look at your market share in the Medicare services. We could look at the specific cost and reimbursement for certain services that the hospitals is interested in. The vision for these additional data analyses that we provide is to support hospitals with the discussions with the board and the community members to understand what the current situation is and what the potential situation might be. In addition, if you are a hospital CFO or CEO and you want to really understand some of the ideas that you have for potential reconfiguration of the services that you are planning, that's the place where we come in and to support your decision making using the data that we have available to us. So with that, I think I'm going to turn to our last poll with Candice, and then there are some questions that we are going to take that we can address on financial modeling as well. Candice?
Yeah, thank you, Shule. All right, so another poll beyond the financial. So Janice went through quite a bit in terms of technical assistance, but thinking about those hospitals who are considering REH conversion beyond the financial assistance, what other technical assistance might your organization need to support your hospital conversion? So I'm going to launch a poll here. Oh, now you should see it. Now there's quite a few things listed here, and this list sort of aligns with the list that Janice shared earlier. But if there are other things in here, feel free to type in something else. And if you want to type that into the chat, if there's some other technical assistance that's not listed here, go ahead and select something else, and then you can type your response in the chat. I'm so pleased to see the questions coming in through our Q&A feature. We'll be getting to those questions here in just a moment. All right, so I'm going to give you about 10 more seconds to finish the poll. Share the results. Five more seconds. All right, just taking a quick peek here. It looks like several of you are looking at community and board engagement, something that we certainly have ready. Quality performance management. Some of you are interested in grant writing and proposal development. I'm going to keep this one open just a little bit longer. If you didn't have a chance to fill it out, feel free to fill that out. I'll close it here in just a second. All right, so there are several of you who posted questions in the chat, and I think we're going to go ahead and take those questions first. We do have some questions that were considered prior to this webinar, but we're going to take your questions first. But Janice, I think there's one more thing you wanted to go over before we get to questions.
Yeah, so it's a good framing for questions, because often in the TA center, we do get the general question, well, you know, what does the hospital look like that's reaching out to you? And so we wanted to point folks to an early learning white paper that we put out there in the public space, I believe about a week ago now. And sharing with you the table that we had in that early learning brief about, you know, the hospitals that we're working with. Generally, what does this look like? You know, from I would say bed count, you know, operating revenue, daily census, et cetera. So of, you know, the hospitals that we've worked with that have advanced to the modeling, this is generally the averages of what we're seeing as it relates to that financial, when we go to the next step and they say it's worth. So we've had 104 hospitals reach out to us. About 50% of them have chosen to go to step 2. This is really, I would say, the early learning of the 50% that have chosen to advance. And so again, sharing that because we get that question a lot. We're very transparent in our work. And so wanted to tee that up for folks today. So Candice, I'll turn it back to you to moderate the Q&A.
Yeah, great. And we're getting some great questions in here. You know, earlier in the presentation, Janice, you talked about the timing of the application process. And one of the examples that we said that could hold up timing might be, you know, if there were staffing issues at the state office. Question is, what do you mean by state office, staff availability? Are you referring to the state licensing departments when we say that there could be potential issues there?
Yes, a great question, and thank you for asking for clarification. So yes, given that this is really done in collaboration between federal and state, regulatory, in order to do, any type of follow-up, are the REH regulations even written at the state level? So, we find that some might have the licensure type, but the actual, regulatory, the next level down might not be quite ready to go. So again, it's where is the state at, the federal, because it's a partnership. And so that's what I meant. It's really the regulatory agencies at the state. And are they ready to process? Is everything in place for those organizations to actually process the applications as they come in from the hospitals?
Excellent. Janice, you referred earlier to the option to convert back to a critical access hospital or PPS if they meet all of the requirements. There's a question about what would the time frame be. I suspect the answer depends, but I'll let you answer that question.
In order to convert back. So is the question, I'm interpreting the question as I become an REH and I decide I don't want to be an REH, how quick can I go back? That's how I'm interpreting the question. And again, I don't know that there's a defined period of time stated anywhere. Please, if one of my team members, if I'm stating this incorrectly, correct me. Based on my knowledge, there's nothing written that you have to be an REH for X amount of time. It's really going to depend on that meeting the current conditions of participation to go back to become a critical access hospital or a PPS hospital and meet all of those requirements. If you've given up inpatient as an REH and you need to build some of that back in order to meet current hospital regulations, it could take you time. So very much, Candace, it does depend. There's nothing statutorily in writing that says you have to be an REH for X amount of time before you can convert back. It all really becomes about meeting the conditions of participation.
Yeah. Another really great question for our speakers today is related to the bed count. So we've talked a lot about the bed count, and I'll just note that there's quite a bit of information in this slide about the bed count, not only in the presentation itself, but also in the appendix. But the question is, what if our hospital expanded to 200 beds due to the public health emergency? Would we still qualify as as an REH?
Again, it's going to come back to that calculation. To date, we have seen zero flexibility as it relates to those qualifying criteria to meet the eligibility. So, it's hard to say without a specific example. But, from where we sit in the TA center, it's pretty consistent that it goes back to that date cost reports and meeting those eligibility criteria at that point in time. To my knowledge, we're not aware of any waivers that have been granted specific to the public health emergency.
Thank you. Great question here. We didn't address this in this presentation, but I'm just going to take this opportunity to plug for the frequently asked questions available on the Rural Health Redesign Center website, rhrco.org. That does address this question. Can an REH own and operate a or multiple rural health clinics?
So the answer is yes.
And if I can follow up on that one, if you go to the slide 41, we were also preparing for a question around the OPPS payment rates. So the way the nomenclature there is an REH services. So those are set of services that receive OPPS payments with 5% enhanced payments, and they include emergency observation and other outpatient services. But REH can provide other services as well, which are paid on a fee schedule. So there, you can think about your therapy services, a clinical lab that is paid on the clinical lab fee schedule, and REH is part of those as well. So there is no change in the provision or the payment for rural health clinics if the hospital is operating it. Provider-based clinics as well. So when we think about REH services, we are thinking about the enhanced payment that is paid under OPPS, but the rural health hospitals could provide additional services and they are paid on the fee schedule. The distinct unit part, I think this question came as we were discussing that the REH can have skilled nursing facility. Janice was referring to the other distinct parts, like you may have had rehab or psych beds as a distinct unit. In addition to closing the acute inpatient beds, you will be closing those distinct part unit beds as well as the swing bed unit. So the only thing that you could have as a bed is the skilled nursing facility that you want to have a separate license for.
Excellent, thank you. Another question posed, and this is really about earliest conversions. Is there any data that supports early conversions, speaking to improved access to healthcare for those communities? And is there any financial data showing REH conversion has improved the financial status of those facilities?
So I'll take a stab, and then Shule, if you want to jump in, because this is so new, data always lags quite transparently. So, the first REHs only became REHs in earlier in 2023. So we don't even have, quite frankly, a year's worth of data. And so, we have we've certainly heard anecdotal feedback from, hospital CEOs that it seems to be working, the fixed facility payment. So anecdotally, we've heard that, but we've also seen in the news where some REHs made the conversion and it wasn't enough and they still ended up closing. So really, I would say generally, because of the data lag, it's going to take us a little bit of time, and other researchers, quite frankly, time to actually follow the data to say, I can certainly tell you some of the action plans that we're doing with our hospitals. They are looking to how can I expand. So if I had an inpatient census of 1 or 2, and granted, those patients might have to leave the community, but there are other services that I could actually bring in within that fixed facility payment, as well as the other reimbursement structures, as Shule has already talked about. So we do know from some of the hospitals that we're working with as part of their action planning, they are looking and trying to identify expanded services that they could bring their community in the outpatient space. But, data to say, yes, health has been improved in these communities. Unfortunately, we're not there yet because of the amount of time it will take to get that data and assess that data.
And yeah, I must add that we are tracking those hospitals. So as data become available, I think REH, Resource Center is going to look at what is happening to those hospitals, whether they received services from the tech center or not. We'll be looking at that. And on top of it, I think that's where comes the financial modeling a little bit. We do see that, once we do those modeling, if you have a negative margin, it improves, but maybe sometimes it doesn't come to a positive one. So that's the place where the coaching comes in, and the additional data analysis and scenario building comes in to understand and help hospitals how they could create financial viability under REH program.
Yeah, excellent. This next question, I think it really gets to how can, based on our engagement with hospitals and state offices, are there things that hospitals can do to support state agencies as they're considering this as a legislation? As we know, some of the states have passed legislation that support the REH and others have not. Are there suggestions that hospitals might, or steps that they might take to support state offices?
I would just say communicate. If REH is something that you think provides a viable path forward, or you want to assess it, again, we also get the question, do I have to wait until my state passes, legislation or is ready to go in order for me to assess this? The answer to that question is actually no. If you want to understand what this means, reach out to us. We can help you, because that data actually may help inform folks at the state in terms of helping them. So I would say communicate. If this is something that you're interested in, make sure folks in your state know that. Reach out to us and, get in our cohort experience so that we can provide you with the information that you may need in order to educate. So, the highest level, communicate the need, make sure you're the right folks at the state understand that you're interested in at least assessing it, and bring them to the journey with that information.
And can I add also the National Academy of State Health Policy has published a lot of templates. So you could also communicate that the state doesn't have to discover everything from the beginning. There's already quite a bit of templates and support in terms of the legislative changes. But as Janice mentioned, starting with TAC, because Janice kind of keeps track of everything going on around this, that she could point you to right resources as well.
And that's a nice segue into our final. I will say that we started to look at these two slides here. Again, these slides will be available for download within about a week from the Rural Health Redesign Center website. But there are a few questions in here that you might be interested in seeing, in addition to our frequently asked questions. We didn't get to these questions today. I think Shule just hit on one of them, but want to encourage you to download the slides to get additional information. At the end of this presentation, we've also included links to several resources, including our frequently asked questions and other resources that might be helpful if you're considering conversion or want more information about the Rural Health Redesign Center. If you're interested in conversion, if you simply go to our website, at the top you'll see programs. You'll see the Rural Emergency Hospital. There's an expression of interest form. Again, as Janice mentioned, there's no obligation to convert. If you're just interested in learning whether or not your hospital qualifies and are interested in a financial analysis, please reach out to us. With that, I'm going to close the presentation and encourage all of you to go to our website and find out information if you're looking for interest or if you just want to download the slides in the recording. Thank you all and have a great afternoon.